All right, we're going to go ahead and get started with today's webinar. For those of you who I don't know, my name is Michael Kriss. I'm a transplant hepatologist at University of Colorado, and today I've been tasked with discussing the diagnosis and management of clinically significant portal hypertension, and I've redubbed this, what's the significance of clinically significant portal hypertension? A few housekeeping slides. Here's information regarding accreditation and designations for CME and MOC. Regarding disclosures, I have no financial disclosures relative to the work discussed today. And then upon completion of today's webinar, you can access an evaluation via this link or QR code. I'll also show you this at the end of the talk. That evaluation will close at 5 p.m. next Tuesday, and subsequent certificates for CME and continuing nursing education will be reported out the following day. Okay, so without further ado, I really want to focus on 4 pieces today regarding clinically significant portal hypertension. First, I want to recognize what's the clinical data that supports the significance of that diagnosis. Then I'm going to spend some time discussing tools that most of you may be using in your practice already to identify clinically significant portal hypertension. And then I'm going to spend really the majority of today's time on medical interventions to specifically mitigate complications of clinically significant portal hypertension via direct treatment of portal hypertension. So I'm going to keep emphasizing that when we get to that section. And then we'll conclude with some updates relative to recognizing patients who are appropriate for liver transplant referral once you diagnose them with clinically significant portal hypertension. All right, so while many of you may have been in practice, even perhaps predating the PubMed here, but the concept of clinically significant portal hypertension is not new clinically. You know it when you see it. But this research concept of clinically significant portal hypertension is actually a new paradigm that's really only evolved over the past 2 decades. And this is evident in the citations noted from PubMed that bear this term within the title or body of the work. So clinically significant portal hypertension is defined as an HVPG, or a hepatic venous pressure gradient, greater than or equal to 10 millimeters mercury. Now, that's clearly stated in all of our guidance documents. Many of you are already kind of familiar with this from a clinical perspective. But the question is, well, why is that number the number, and why is it clinically significant? So the most recent portal hypertensive bleeding and cirrhosis guidelines from AASLD actually provide a nice framework to think about these patients. And as I think many of you have become accustomed to, we have started to clinically define cirrhosis based on stages of decompensation, which help us define and predict endpoints such as death or liver transplant. I think what we need to think about is making sure we always divide these patients into compensated and decompensated. That's not really novel. Decompensated patients, you know them when you see them. They're going to have usually multiple complications that are clearly evident when you walk in the room. We're rarely needing to get HVPG measurements, though the HVPG is greater than 10 to 12 millimeters mercury. And really, in those patients who have these complications present, including varices, the goal is to control acute issues when they arise, prevent rebleeding when it occurs, and prevent further decompensation, and in many instances, try to optimize these patients for liver transplantation. Those patients are going to be kind of overlooked in today's talk. I will show you some data on them, but we're really going to focus primarily on the compensated side. And I think everyone is comfortable saying that a patient with a HVPG that's less than 10 millimeters mercury, does not have varices, and does not have complications of portal hypertension is a compensated cirrhotic. And really the goal in those patients is to prevent clinically significant portal hypertension. What becomes a lot murkier is this patient population that walk in the room and they look good to you, but on the inside, they're not good. So these are patients who may look, quote unquote, well or compensated, but have clinically significant portal hypertension. These patients can actually even have varices present, and they still will be categorized using this paradigm as compensated. And the goal in these patients is to prevent further decompensation. We're going to spend the bulk of today's talk really zeroing in on that patient population. Now, one thing I want to note in this less than 10 millimeters mercury HVPG subgroup of compensated cirrhotics is we need to make sure we're thinking more broadly. And in fact, the ASLD guidelines say that this group is actually should be referred to as compensated advanced chronic liver disease. And that just acknowledges that portal hypertension, defined as a HVPG over 5, can be present even in the absence of cirrhosis. And I think many of us are seeing that in our clinics, for instance, in patients with NAFLD or now MASLD and MASH. But as I mentioned, we're going to really focus in and zero in on this specific patient group. So how did we get here? How did 10 become the number? So this happened in 2007 with a publication that was a nested cohort study. So they took an initial study that included almost 800 patients who were screened for varices and had HVPG measurements. And they took a cohort from that was 213 patients who had compensated cirrhosis, portal hypertension as defined by an elevated HVPG, but without varices. So these are those patients who truly have no decompensating events. And actually, the secondary outcome in this cohort study was determining the ability of the HVPG to predict subsequent clinical decompensation, and the median follow-up time was just over 4 years. In this cohort, 29% of patients developed a decompensating event. And when they analyzed all the laboratory data, all the clinical predictors, and stratified HVPG measurements, they discovered that the single strongest predictor of decompensation in these patients was those who had an HVPG greater than or equal to 10 millimeters mercury. Now, this isn't perfect. And if you look at the Kaplan-Meier curve, you can see that in the extended follow-up, 10% of those who had an HVPG under 10 did develop decompensation. And certainly not all of the patients who had an HVPG above 10 developed decompensation. It was actually only 40%. But it's clear that this has clinical significance in its ability to predict subsequent decompensation. And that's why it's been dubbed clinically significant portal hypertension. Now, we can put a label on it, but we got to identify it in our clinics. So how do we do that? I'm going to go through some tools that many of you are probably already using, but demonstrate some of those that you're maybe using but not relating to clinically significant portal hypertension may also be valuable. Now, it's clear from this initial study that HVPG truly is the gold standard for clinically significant portal hypertension. And for those not familiar, I would just give a footnote that in Europe, hepatologists perform HVPG measurements, not interventional radiologists alone. And that's why there is an abundance of clinical data, primarily from Europe, that integrates HVPG measurements into clinical trial and outcomes. Now, in the United States, we rely on our interventional radiologists, and this requires catheter access to the hepatic vein, usually through the transjugular vein. You access the hepatic venule, or the venous outflow. You measure a free hepatic vein pressure, and then you inflate a balloon at the tip of the catheter, and in the small circle insert there, you can see that that would create a static column of fluid across the sinusoids, which then allows you to transmit the pressure from the portal venule and indirectly measure the portal pressure. The gradient between those two is what then becomes clinically valuable for us, and that's what's defined as the HVPG. In the bottom right, you can see how that tracing plays out in real time. You define the free hepatic vein pressure, in this case 10, and you can see variations with the cardiac cycle with measurements all taken in diastole. And generally, there's 3 sets of measures taken to then aggregate that data and generate an HVPG for that patient. Now, that's great, but we're not doing HVPGs on all of our patients. In fact, we're not doing HVPGs on most of our patients. So what can we use? Well, most of us have become now facile with utilizing elastography to measure liver stiffness in our patients. primarily for fibrosis staging, but there is an abundance of data in using this tool to detect clinically significant portal hypertension. What I'm showing you here is data from a meta-analysis of 5 studies, and that included 420 patients. Now, interestingly, the individual thresholds within these 5 studies were very heterogeneous, ranging from 13.4, which I'd argue is too low, to 34.6, which is probably too high. And it did have a cohort that at the time, there was a large population of untreated viral hepatitis. So you could argue the applicability now in the DAA era, but there was also a large alcohol cohort. Regardless of that, you can see that in correlating liver stiffness to the presence of clinically significant portal hypertension, this had a very high sensitivity, specificity, as well as a high positive and negative predictive value. And if you look to the right, what is shown there, each open circle is the study estimate for sensitivity and specificity. And from that, they were able to aggregate a receiver operator curve. And you can see that if you look at what's the equivalent of the area under the receiver operator curve to detect clinically significant portal hypertension in these studies, that performance was 0.93. So that's really bordering on what would otherwise be considered a gold standard. Now, I'm going to show you some additional data, but in general, the proposed thresholds for clinically significant portal hypertension based on liver stiffness range between 20 and 25 kilopascals, though I would note that in this meta-analysis, only 2 of those 5 studies had thresholds within that range. So how can we rule this in? So this, I think, becomes clinically applicable in the patient who, to you, looks pretty good. But you then do this test and are surprised, perhaps, that they have clinically significant portal hypertension. So this study sought to answer that question. It was a prospective study and one that was included in that meta-analysis I just showed that included 250 patients. This was the low threshold study of 13.6 kilopascals. But they further grouped patients based on presence or absence of thrombocytopenia, defined by a platelet count of 150,000, and presence or absence of splenomegaly. And in a subgroup of those patients, so 40 of the 250, they actually had HVPG measurements. And they actually then did additional threshold analysis using the different thresholds that are depicted in the dot plot to your right. And I want to draw your attention to 2 things. First, if you look at the black dots, that's using this higher threshold of 25 kilopascals and applying that to all 3 clinical groups. There's only a single patient that would have technically been missed as not having clinically significant portal hypertension, but in that case, their HVPG was actually 9. So this 25 threshold is actually probably a really reliable rule-in threshold. The rule-out threshold is a little murkier, and in this study, they used a lower threshold of 21.1, and you can see that in the white dots, you are still having patients who, despite having that lower liver stiffness threshold, are being identified on HVPG as having clinically significant portal hypertension. Now, we can correlate the liver stiffness to an HVPG, but does it have the same clinical relevance? And this study aimed to answer that specific question. So this is a prospective study of 100 patients who had compensated liver disease, all of whom underwent transjugular liver biopsy with an HVPG and a baseline liver stiffness measurement. They were then prospectively followed for 2 years until they developed clinical decompensation, transplant, or death. And in this study, they specifically compared that lower threshold of 21.1 kilopascals to an HVPG of 10 millimeters mercury, which is our defined threshold for clinically significant portal hypertension. And if you look at the Kaplan-Meier curves on your right, you can look at these and they look essentially identical. And I promise you, I did not just copy and paste these and relabel them. These are how the data played out. So the liver stiffness not only correlates to the HVPG well in general, but it also bears the same clinical significance to predict subsequent decompensation. And the one thing that I would add is that in this study, because biopsies were done, only 65% of these patients actually had biopsy-proven cirrhosis. So this does underscore that concept of CACLD, where these patients may have portal hypertension even in the absence of cirrhosis. But in those 65% who did have cirrhosis, using that lower threshold had a 100% negative predictive value to exclude portal hypertensive complications in a mean follow-up period of 491 days. So it's probably a good metric, and you'll see numbers that range as low as 20, I think, to make it even. But this is the data that supports that. Now, with that in mind, I do want to show you what the most updated Bovino 7 now consensus document supports. And for those not familiar, this is a working group that meets periodically to establish guidelines for the management of portal hypertension and its complications. And what they have actually proposed in their latest guidelines that are now just over a year old is the so-called rule of 5 when you're using liver stiffness. So they agree that a threshold above 25 kilopascals rules in clinically significant portal hypertension. But they actually have a much more conservative threshold for excluding clinically significant portal hypertension with 15 kilopascals. Although, as many of you know, you can use a threshold of 20 with a platelet count above 150 to essentially avoid endoscopy, in the sense that it's very unlikely that those patients will have high-risk varices. So this is another way to think about this when applying liver stiffness. All right, so those are like our nifty tools, but like, what about the things we do every day for our patients, and how accurate are those to establish clinically significant portal hypertension? Well, many of us are routinely performing screening endoscopy in our patients in whom we have a suspicion for clinically significant portal hypertension. And even in patients with small varices, as pictured here, have, by definition, clinically significant portal hypertension. If you have that endoscopy picture, you have established that diagnosis in your patient. Similarly, cross-sectional imaging, if it shows portosystemic collaterals around the gastroesophageal area, are adequate to establish a diagnosis of clinically significant portal hypertension. And in fact, there's a study from Mayo that I'm showing you here that compared triphasic CT of the liver to endoscopy. And triphasic CT was 90% sensitive to detect esophageal varices that were subsequently seen on endoscopy. All right, now the other imaging we're ordering routinely in these patients, oftentimes for HCC screening, is ultrasound. And if you see hepatofugal flow, or flow away from the liver on ultrasound, that also is adequate with 100% specificity to establish a diagnosis of clinically significant portal hypertension. And while this is going to be reported out by the radiologist, for those of you that are looking at these studies, you can see that a negative velocity in centimeters per second, so demonstrating flow away from the liver based on that negative value, helps establish that hepatofugal flow. Okay, so now we have a lot of tools to try to identify this cohort of patients without doing HVPG measurements. And as you can appreciate, those are a lot of those tests we're doing routinely in these patients with compensated cirrhosis regardless. And so while we can't necessarily exclude clinically significant portal hypertension in the absence of some of those findings, we can certainly establish it when present. All right, so now that we can understand the significance of this and identify patients with it, I want to really spend the bulk of our time now talking about medical interventions to mitigate complications of clinically significant portal hypertension. And I want to bold, italicize, underline medical interventions. I'm going to only briefly mention, for instance, tips. And we're really focusing on treating the portal hypertension, not necessarily the complications that arise from it. So for instance, we're not going to talk about diuretic management for ascites. We're going to talk about how we can mitigate the portal hypertension that's driving that ascites. So you're all familiar with Ohm's law, which helps us define the factors that contribute to portal pressure, which are flow through the portal system, and then resistance in the hepatic parenchyma due to both inflammation in some instances and scarring. Now, as far as things that we can use to manage flow medically, there's several acute things we use: octreotide, vasopressin, and now terlipressin. And those are really to treat these complications when they arise. I'm not going to go into detail about discussing those. Okay? There's pretty clear indications for those. We know how they work, what effect they have, but it's really trying to temporize changes in portal hypertension to treat acute decompensation. What we do use chronically and we're going to spend the bulk of the time talking about, are non-selective beta blockers. So non-selective beta blockers traditionally are beta-1 and beta-2 agonists, and these do two things physiologically. They reduce the cardiac output by reducing the heart rate, and then because there is unopposed alpha activity, there is splanchnic vasoconstriction. And so that's the dual mechanism by which these work. Now, when it comes to resistance, again, specifically discussing medical management, carvedilol, which is, I would encourage you to think of traditional non-selective beta blockers and carvedilol as separate but related. And that's because carvedilol, in addition to its non-selective beta blocker function, has alpha-1 antagonism activity. And what that does is there's then unopposed alpha-2 activity. And it leads to intrahepatic vasodilation through smooth muscle relaxation. So there's an additive benefit to carvedilol from a physiologic perspective. Now, there is some experimental data that statins via induction of nitric oxide production could have a similar effect. And in fact, there's a large NIH-sponsored multi-center consortium being built to study this. And then there's several other agents like IMDR and ACEs and ARBs that are clearly effective, but just aren't tolerated in our patients with cirrhosis, so things that we don't use clinically. Now, the only other thing that I will mention, because this is dependent on the stiffness or resistance, I should say, flow through the hepatic parenchyma, treating underlying primary liver disease, so for instance, treating hepatitis C, does actually lead to probably a change in resistance of blood flow through that liver. So don't forget about etiologic management in these patients. Okay, now putting this all together, you can see our pharmacologic or medical tools here, as well as some of our IR and endoscopic interventions. And the name of the game is trying to really reduce portal inflow and hepatic resistance to then ameliorate the portal hypertension. And we're going to talk about this within the framework of varices. And the reason we're going to do that is because, one, that's how this has largely been studied. And two, varices present usually the most imminently life-threatening complication of portal hypertension in our patients. Now, as I was preparing this talk and thinking about talking about varices as they relate to portal hypertension, it got me thinking about how we grade varices. And starting in the mid-60s with the advent of rigid endoscopy, there have been over a dozen different grading systems of varying complexity. And if you look initially, there was a size metric only, which, as I'll show you, we've come full circle on now. But then there's a whole series of qualitative findings that are described, many of which we still use, such as cherry red spots and white plugs or fibrin plugs. And then a lot of these were very qualitative. So you can look at things like form, color, red color signs, percent lumen occupied. And while some of these were designed to predict bleeding, they really didn't provide a uniform way to communicate amongst not only hepatologists, but like to identify cohorts of patients to do meaningful clinical research on them. So I'm kind of glad there was this long and winding road to get here, because in 1990, a group of hepatologists in Europe convened the first ever Bovino consensus development workshop at Lake Maggiore in Bovino, Italy, which is pictured there. And they said, this is insane. We just have to simplify this. And so from that, we have developed this size thresholds of less than 5 millimeters for small, usually low risk varices, or greater than 5 millimeters to declare large or high risk varices. And we've now added certain qualitative features that have been defined in the past, including red whale spots, which, if present on small varices, make them high risk, and the presence of clinical Child-Turcotte-Pugh class C, and in patients with even small varices technically denotes those as high risk. Now, when it comes to varices, we know that in our compensated cirrhotics, so those patients who were most interested in intervening in their clinically significant portal hypertension, 40% will actually have varices. Once those patients develop additional decompensation, 85% will have varices. And when we look at the progression, patients develop varices at a rate of 7 to 8% per year. They develop progression of small to large varices at a rate of 10 to 12% per year. And then those large or high-risk varices bleed at a rate of 10 to 15% per year. And once that bleeding event occurs, the 6-week mortality is 15 to 25%. So these are not trivial numbers, especially given the not only national but global burden of liver disease. So using this progression paradigm, we can identify then clinical goals for intervention of portal hypertension. So we can talk about preventing the development of varices, or so-called pre-primary prophylaxis. We can talk about preventing progression of varices. Once those patients have high-risk varices, we can talk about reducing portal pressure to reduce their risk of first bleeding event. And once they've bled, we can try to do things to reduce their risk of rebleeding. And so we're going to actually work through this progression as a model to understand the data that supports medical interventions, primarily non-selective beta blockers, for the treatment of portal hypertension. So we'll start with prevention. So in 2005, this really seminal paper was published in the New England Journal. And it came from Europe. It was a placebo-controlled randomized controlled trial of 213 patients. They were randomized to receive either timolol or placebo. And this was a cohort of patients that were your compensated patients who did not have clinically significant portal hypertension, right? Because they didn't have varices. And that mean HVPG in the cohorts was 6. The primary endpoint was development of varices, or if they bled, they obviously clearly had varices. And they underwent annual EGD and HVPGs. And while there was a clear hemodynamic effect of a 17% reduction in heart rate in the timolol group to a mean baseline heart rate of 61, on the right, you can see the Kaplan-Meier curve shows no difference in the probability of developing varices over the study follow-up period. What's also noted in this study is that there were increased adverse events in the timolol group, and specifically a 3-fold increase in serious adverse events. So you can imagine that there was probably some excitement, and then really this landed with a thud. And I think the editorial that was published alongside it really captures the disappointment. Beta blockers to prevent esophageal varices, an unfulfilled promise. And so this was really the start and end of pre-primary prophylaxis to prevent this progression. Now, there is probably a reasonable physiologic reason why this didn't work. And it's because in patients who have not yet developed clinically significant portal hypertension. So they may have portal hypertension defined by that HVPG being over 5, but not over 10. In those patients, they have not yet developed the physiologic changes that lead to a hyperdynamic circulation. And that doesn't occur until patients develop clinically significant portal hypertension. So the physiologic effect of these non-selective beta blockers is really not able to exert an effect on the pathophysiology because it's not yet developed. So I think this is a reasonable explanation for why this doesn't work in prevention. All right, we can't prevent them, but can we prevent progression once you have them? Now, I think most of you are hearing me say this and you're saying, well, no, this is another negative study. And it's because it's not something we routinely do. But let me actually show you the data, because I think your tune may change. So while there was an initial study of nadolol that actually showed a 2-fold increase in rate of variceal progression in the nadolol study, there has since been data that refutes that. This is a study that was a single-blind placebo-controlled RCT of 161 patients. And I'd add that most of these studies are single-blind because of the nature of titrating beta blockers and performing endoscopy. All patients in this study had small varices, but it used a classification system called the BEPU, and specifically the form subgroup of that classification that is qualitative. So F1 was straight varices. These patients were sicker than the study I just showed you. They had an HVPG at baseline of 12. So these are our patients with clinically significant portal hypertension as supported by the presence of varices. They were then given nadolol or placebo and followed every 3 months with no less than an annual EGD. And the primary endpoint was progression of varices, but again, based on qualitative criteria of either enlarged tortuous varices or, quote, largest sized varices. Now, on the right, you can see the Kaplan-Meier curve, and there's a clear benefit to nadolol. So they're actually showing you here the probability of being free of EV progression. So higher means less progression. So nadolol does reduce that rate. In the study, they did not show any mortality benefit, interestingly. And so I think that's perhaps why this didn't really catch on, along with the fact that it had a counterpart study that refuted this. But about a decade later, along comes carvedilol. And almost the same study was done, this time with carvedilol, and this time with a much more objective measure, using size as a distinction for small varices, and defining progression as development of large varices. EGDs were performed actually slightly more frequently in this group, every 6 to 9 months, and there was an HVPG measurement at baseline and at 1 year. And these patients had clinically significant portal hypertension with baseline HVPGs in the 14 to 15 range. And I'm showing you the intention to treat analysis, but the per protocol analysis was almost identical. And you can see that again, patients in their carvedilol group had a higher percentage of being free of EV progression. So they were less likely to develop progression of varices. But what's additionally noted in the study that's novel is that there is a survival benefit. And what's further interesting in this study is there is actually no difference in HVPG. So there's a question as to what was really driving this benefit in the study. Now, based on that study I just showed you was published in late 2017, and our most updated AASLD guidelines on portal hypertension management, specifically relative to bleeding and varices, was published in early 2017. So our AASLD guidelines do not support use of, in this case, carvedilol to prevent progression of varices. However, in the updated Bovino guidelines, which were developed in 2021 and published in 2022, they do explicitly state that this should be used to prevent decompensation, which includes progression of varices. All right, so what about in our patients with high-risk varices, in which their portal hypertension is more significant? How do we achieve primary prophylaxis? Again, by treating portal hypertension. So this is a meta-analysis of 8 placebo-controlled clinical trials. They used either propranolol or nadolol. All the patients had varices that in the studies, they were all followed for a period of at least 2 years. And if you look at all comers, so patients with small or large varices, there was a 10% absolute risk reduction in variceal hemorrhage for all patients. So the number needed to treat to prevent 1 variceal hemorrhage was 10, which is pretty good. If you actually take patients who had high-risk varices, that number goes up even further, and there's a 16% absolute risk reduction. And on aggregate, there was a small absolute risk reduction in mortality of 4%. Now, one thing I will note is that in this meta-analysis, these studies titrated to a goal heart rate of 55 to 60, and 15% of patients discontinued medication due to side effects, and another 15% actually had contraindications. So this is a great tool for probably about 2/3 of our patients, if we're still talking specifically about non-traditional, non-selective beta blockers. Now, what about carvedilol? Okay. So there's been a lot of literature published now on carvedilol. This study, I think, is interesting because it took a stepwise approach in a cohort of patients who had clinically significant portal hypertension but had not yet had variceal hemorrhage, and tried them on propranolol first. If they failed that, they moved to carvedilol. If they failed that, they used band ligation. And those were all tools for primary prophylaxis. And they also assessed HVPG. That's how they essentially determined, quote, response. And you can see in aggregate, there was a greater percentage of patients that responded to carvedilol, 57% versus 39%. And there was also a greater percent reduction in HVPG with carvedilol, and that was 19% versus 12% with propranolol. And keep in mind, that carvedilol cohort are the patients who failed propranolol. So carvedilol probably is better, and this is a study that's really helping to directly establish that. In this study, there was actually no significant difference in the mean arterial pressure or heart rate between the two groups, but I will show you some data where there probably is an effect, specifically in carvedilol because of its alpha-1 activity. on mean arterial pressure. Okay, so I'm kind of setting the stage here that carvedilol might be better. But what about in patients with advanced disease? Now, this is a study that was published in 2016. And it took 110 patients, and they specifically compared carvedilol to propranolol. And these patients, again, had baseline HVPGs greater than or equal to 12. So technically, these are patients with more probably decompensated disease who had grade 2 or 3 esophageal varices. And patients had a baseline HVPG, were then put on study drug, and then an HVPG repeated 6 weeks later, and they assessed the percent response. And response was defined as a HVPG that decreased by more than 20%, or if it fell below 12. And on the left in that table, I'm showing you the hemodynamic metrics between the two, and none of these were statistically significant, including the HVPG. However, if you looked at patients who had responses, there was a slightly higher percentage, or I shouldn't say slightly, but a higher percentage in the carvedilol group, 49% versus 30% in the propranolol group, though that difference was not statistically significant. So you're probably like wondering, like, what is Kriss doing right now? He's showing us a negative study that is not showing superiority in advanced disease. But the reason I like this study is they then actually took the same cohort and they divided it based on 3 different metrics of liver disease severity: the MELD score, Child-Pugh score, and the presence or absence of ascites. And this is really remarkable, because if you look at patients who had more advanced disease based on a MELD greater than or equal to 15 or a Child-Pugh score greater than or equal to 9, none of those patients responded to propranolol, 0. Whereas 58% in carvedilol, 58% in the high MELD group and 46% in the high Child-Pugh group responded to carvedilol. And you can see that there's not that difference in response in the less sick patients. First, the patients with ascites, there was some response to propranolol, but the rate of patients that responded to carvedilol was twice as much in that ascites group. And again, that difference was lost in patients who were less sick based on the absence of ascites. So this really does start to establish at least hemodynamic superiority of carvedilol in patients with more advanced disease. Now, you're hearing me say this, and then you're saying, wait, I feel like there was like this period of time where the only thing hepatologists talked about was how you couldn't use non-selective beta blockers in patients with ascites because it would lead to their untimely death. And this was the topic of every academic debate for every meeting that you attended for a 1 to 2 year period. And this is a concern. And this study is actually what bore a lot of the evidence to support that concern. But really, it's the concern that carvedilol specifically can impact renal perfusion. And the way that this is thought about from a clinical paradigm perspective is patients develop changes in cardiac contractility that lead to that hyperdynamic circulation. They have changes in renal perfusion pressure from portal hypertension, and they have sympathetic activation. And that sympathetic activation and cardiac contractility increases or hyperdynamic cardiac function are compensatory to try to maintain that renal perfusion. And there is probably a threshold beyond which renal autoregulation fails, and that's when our patients develop things like hepatorenal syndrome. And generally, we see this in patients with refractory ascites. And the concern is that if you blunt the cardiac function with a non-selective beta blocker, and or you blunt sympathetic activation with carvedilol, that you will then in turn drop these patients below a threshold of autoregulation and precipitate renal dysfunction. So this study, while small, included only 38 patients, was really quite instrumental in establishing this as a problem. And they had 18 patients who had diuretic responsive ascites and 20 that had refractory ascites. And they measured essentially a marker of systolic function, renal perfusion pressure, creatinine, and several other cytokines. And on the left, what you can see here, on the top, the EIV-PD is a measure of cardiac contractility. So think of that as kind of a surrogate of an ejection fraction, essentially, or maybe more appropriately, cardiac output. And you can see that in patients who had diuretic responsive ascites who were put on non-selective beta blockers, there was no difference with the non-selective beta blocker. But in those with refractory ascites, there was a significant decrease overall in that measure of cardiac contractility. Similarly, renal perfusion decreased in both cohorts. So it decreased in the diuretic responsive ascites group and decreased in the refractory ascites group as well, but there was a lower starting point in the refractory ascites group, and those patients on aggregate fell below a threshold of a renal perfusion pressure of 65 millimeters mercury. And if you then looked at patients, kind of took the inverse of that, so looked at patients who had the lower renal perfusion pressure, that was essentially all the patients who had reduced cardiac contractility, and those are the same patients who then bumped their creatinine. So this really establishes at least that physiologic concept that there probably is a, quote, window to use these medications. Now, I think this, quote, window got kind of extrapolated to this, you were actually potentially harming your patients if you left them on this non-selective beta blocker therapy past that window. And I want to set the record straight, that is definitively not true. So specifically, carvedilol does not increase mortality even in patients with refractory ascites. And this has been demonstrated in now 2 large meta-analyses, one that included over 8,000 patients, the other that included over 3,000, and there was no difference in all-cause mortality in either of those cohorts in patients with refractory ascites. The study that's pictured on the right is actually a smaller study of 325 patients. And these patients were either given carvedilol or had a non-carvedilol group. And these were either placebo or non-active. And this was aggregate analysis here. And you can see that when they divided based on the severity of ascites, you can see a mortality benefit in these patients on aggregate for all patients, but it was most pronounced actually almost entirely in the mild ascites group. The patients with moderate ascites had a more attenuated response that was no longer statistically significant as far as risk reduction for survival. And those patients with severe ascites essentially lost that effect entirely. But note, the patients with severe ascites did not have an increased risk of dying. All right, so what is the window? So, there's all this really ongoing debate about what this is, but I think it can really be quite simplified by just titrating this to a mean arterial pressure. And this is a study that illustrates that point. So this was a single center observational study that looked at 624 patients. And they assessed the impact of non-selective beta blockers on survival in patients after they presented with their first presentation of ascites requiring large volume paracentesis. So the goal was to basically identify these, quote, refractory ascites patients. And their primary outcome was 28-day transplant-free survival. And they looked at the overall survival benefit with non-selective beta blockers, which was present and was statistically significant, but they also subdivided this based on the presence or absence of acute on chronic liver failure. Again, those patients derived mortality benefit, and in patients who had SBP. And while there was a trend towards mortality benefit there, it was not statistically significant. But the most interesting part of the study is that they then also stratified patients based on mean arterial pressure. And if you look at patients whose mean arterial pressure was less than 65, the survival benefit was lost entirely. However, if you look at those same patients who had a mean arterial, or the patients who had a mean arterial pressure greater than or equal to 65 who were on non-selective beta blocker, that mortality benefit was preserved. So really thinking about this as having a mean arterial pressure threshold for when these medications probably do or do not provide benefit, I think is the right way to think about it. All right, now I haven't mentioned band ligation at all, and we are talking about primary prophylaxis, and I practice in my own practice where I primarily do band ligation. But I think actually the data would argue that carvedilol is superior. And it's not necessarily that carvedilol is always superior to prevent bleeding, although this meta-analysis does certainly support that on aggregate, carvedilol is probably better, especially for lower risk varices. But the reason I say it's superior is because there probably is a real mortality benefit independent of this variceal prophylaxis benefit in these patients that you don't get with band ligation. All right. So that was a lot of discussion and some digression as we talked about primary prophylaxis. But what do we do now in our patients who have had variceal hemorrhage and then need secondary prophylaxis? Now, I'm going to just show you some brief meta-analysis data because I think this is pretty well established that the combination of non-selective beta blockers to treat the portal hypertension combined with band ligation and that serial band ligation over time is superior. And this meta-analysis did a nice job of comparing combo therapy to either band ligation alone or medications alone. And in both instances, the combo therapy was superior. Now, while that data is certainly convincing, I do want to show you this newer study, albeit small, just published last year, that actually took 64 patients who had presented with variceal hemorrhage, and after initial hemostasis, they were then randomized as outpatients to either receive carvedilol alone or undergo a series of sequential endoscopies for variceal band ligation. The primary outcome was mortality, and the secondary outcome was rebleeding rate. And on the left, I'm showing you the Kaplan-Meier curve for probability of bleeding, and you can see there is no difference. So these were equally effective to prevent rebleeding in these patients, understanding that risk was still relatively high. But if you look at the right and you look at the probability of survival, carvedilol actually provided a survival benefit. And so this is why I think our practices will probably evolve to integrate carvedilol much more routinely in our patients, because this survival benefit has borne out over and over and over, and in this case is clearly independent of any prevention of variceal bleeding benefit that may exist. Okay. The one thing I didn't discuss yet for secondary prophylaxis is tips, and I don't want to discuss this in detail, but I do want to just draw your attention to the ALTA study group. So this is the study group of 10 large academic centers who have completed and published a retrospective multi-center study of over 1,000 patients who were TIPS recipients. This is in the MELD era using the MELD sodium specifically. And really the goal of this study was to develop a contemporary practice guidance on what patients' true risks are with our technical advances in TIPS. And what I'm showing you here are the 42% of patients who underwent TIPS for variceal hemorrhage. So these were patients who would have then gotten it for, in most instances, secondary prophylaxis. I suppose there are some who had rescue therapy. But you can see that while the traditional threshold of a MELD of 18 has been used, that threshold is actually clearly higher in this patient cohort. If you look at, for instance, death, these forest plots start to separate out at a MELD of 20. And you could argue that based on the transplant forest plots, that number might actually extend even into the low 20s. So I do think we're being a little bit more aggressive based on MELD score alone in who we are considering TIPS. All right, so I just spent like an entire talk on clinically significant portal hypertension talking only about varices. But what about all the other portal hypertensive associated complications? So ascites, encephalopathy, in which we might not think about directly treating portal hypertension to manage those complications, but portal hypertension is the underlying pathophysiologic problem. Well, guess what? Carvedilol wins again. And it actually reduces decompensation risk of non-variceal, non-bleeding complications. And this is data from a competing risk meta-analysis of 352 patients across 4 clinical trials, where they were randomized to receive either carvedilol versus placebo or carvedilol versus band ligation for primary prophylaxis. And you can see that the mean follow-up in these patients was 13 to 36 months. And the primary endpoint they used in the meta-analysis was any hepatic decompensation. So that was ascites, HE, portal hypertensive related bleeding, including PHG. And then the secondary endpoint was death or transplant. And this is really remarkable, understanding that this is pretty robust data. If you look at the right, the carvedilol group had a lower probability of decompensation compared to those who were in the control groups. And ascites was the most common complication that arose. And the difference in the groups was 16% in the control group versus 7% in the carvedilol group for a hazard ratio of 0.49. So this is a pretty pronounced effect, and there were similar benefits relative to encephalopathy, death, and liver liver transplant. So that's a lot of data, but I do think it helps to understand how this has evolved and why, for instance, the updated Baveno criteria basically say that we should be using carvedilol in essentially all our patients with clinically significant portal hypertension, given what are now clear benefits in treating the underlying portal hypertension. Now, I want to conclude with just a couple words on when to recognize this in your patients and initiate early transplant referral. This is work done by my partner, Whitney Jackson, and our team here within our transplant research group. And they looked over a decade and compared what was the probability of patients dying on the wait list versus the probability of dying after live donor liver transplant to really define what's the survival benefit. Okay, we think about like what's your risk of dying, but what's the true benefit? And they compared 1 year survival in these two cohorts. And you can see that what's shown here, a hazard ratio that's below 1 suggests the survival benefit is with living donor liver transplant. That threshold went all the way down to a MELD of 11. And I would argue that in your patients with clinically significant portal hypertension, that MELD score becomes somewhat irrelevant. And so this just underscores that there probably is real survival benefit. Now, I'll make 2 points. The reason live donor liver transplant was used is because that's the only way these low MELD patients currently have access based on our current allocation system. And 2, there are changes that I'm going to show you momentarily that might actually expand access to those patients who don't have live donors. And that's expanded access through the use of 2 techniques called normothermic regional perfusion and normothermic machine perfusion. Both of these are tools to optimize donation after circulatory death organs. This is where we have to wait for the donor's heart to stop, so there's a period of ischemia. And instead of immediately procuring that organ in a very quick fashion to minimize ischemic injury, we actually restore flow either in situ in the donor to their internal vital organs, or in a machine pictured here, this transmedics. Our team has become adept at NRP, and we are now using that routinely in our DCD owners and donors, and it's clear that it improves recipient outcomes and allows us to use expanded donors that we otherwise wouldn't traditionally use with excellent outcomes. And the transmedics will be even more transformational because NRP requires that we send our team, so there is some proximity in time, whereas the transmedics can be shipped and can run for over 24 hours. So it really opens up the geography of how DCD organs can be used. And your patients that have clinically significant portal hypertension and low MELDs who you think aren't referred because they're not going to have access might actually have access, and that access is happening right now. So in conclusion, it's important to remember that the presence of clinically significant portal hypertension predicts the risk of hepatic decompensation on the magnitude of about 40% over 4 years. And while HVPG above 10 is the gold standard, we have a whole slew of non-invasive tools that most of us already use clinically that can diagnose many of our patients with clinically significant portal hypertension. The primary pharmacotherapy to specifically treat portal hypertension are non-selective beta blockers and carvedilol. And I think it's clear that I showed you now an abundance of data that really supports the superiority of carvedilol to not only reduce gastroesophageal progression and bleeding, but also other clinical decompensations and mortality. Be mindful of a patient's MAP, because we know that once that MAP goes under 65, they're going to likely lose that benefit, but you are not going to necessarily be doing harm, although you have to be wary of renal perfusion. And I expect there will be more data to come relative to that. And then don't forget that we now have expanded options to transplant patients who are lower MELD with clinically significant portal hypertension who would clearly derive benefit, and that benefit is clear compared to those on the wait list. So with that, I will conclude. I'm going to leave this final slide on so those of you that want can begin claiming CME or nursing credit for this talk. And I will now open it to questions. I'm going to scroll through the webinar chat here. Looks like I have one question. Is there any evidence that early CoRAG use will prevent development of ascites? If so, what kilopascal would you initiate therapy? So looks like that is from Joseph. Joseph, I showed you that it does in fact prevent development of ascites. And as far as a kilopascal, when I would initiate that therapy, you know, I think I'd probably use something in the range of 15 to 20. It would probably depend on how well I think that patient would tolerate therapy, but I would not hesitate to do so based on the data. Okay, and I think that's all the questions I have in the chat. Are there any other questions that audience members have? You can feel free to enter them into the chat or ask me by unmuting. Hey, it appears there are no additional questions. I did not put my email on here, but because you will have access to the slides, my email is just michael.kriss@cuanschutz.edu. If you do have questions and you'd like to ask me those directly offline, feel free to email me. I do see one more chat message, and that is just a thank you from Lindsay. So thank you all for attending.